Hey, you're listening to MIGS Front Page with Peter Movilla. Today we will be discussing the special article entitled The Link Between Endometriosis, Atherosclerotic Cardiovascular Disease, and the Health of Women Midlife. This special article discusses the potential links between endometriosis and atherosclerotic cardiovascular disease. It makes a point that a physician should consider endometriosis as a non-traditional risk factor for atherosclerotic cardiovascular disease in order to allow for an earlier diagnosis and preventative treatment strategies. We have with us today Dr. Omur Taskin. He's a faculty professor at the University of British Columbia in the Division of Reproductive Endocrinology and Infertility. Thank you so much for being here, Dr. Taskin.
Thank you for having me.
You published a very interesting and novel concept between the link associating endometriosis and atherosclerotic cardiovascular disease. Tell us, what was the impetus for this special article before you published it?
As you all know, endometriosis is an enigmatic disease and nobody has figured out what's going on. But we may be mistakenly or biased on pain and infertility on the masses or endometriomas, not other or surgery regarding how to improve the infertility plus the pain. So, but when you look at the details, if the chronic inflammation is the basis of both disease, so there should be a lot going on. So we prepared a systematic review, which will be published next month probably. It's accepted for publication. In that systematic review, we used lipid profile, systemic inflammation markers, and non-invasive ultrasonography markers to denote ASCVD risk in patients. So we figure out that there is a clinical trend or evidence towards increased lifetime risk of ASCVD in endometriosis patients.
It's a very interesting point. Yeah. And again, it's not something that we're taught in medical school and residency. And even during my current fellowship in minimally invasive gynecologic surgery, we see a lot of patients with endometriosis. So I was very fascinated by your
fellowship too. So so I'm only combining the literature. Actually, there is everything is in the literature.
It's true.
It's unbelievable. But it's separately. Nobody combined those links between cardiology and reproductive endocrinology. That's the point.
Talking about the link between the endometriosis and cardiology, you go through several different proposed mechanisms.
Yeah.
Were there any mechanism that you would say had the most biological plausibility of linking the two diseases that should be investigated further?
When you look at the literature, so most important baseline problem is chronic inflammation or macrophage activation. Now we prepared and submitted a paper regarding innate immunity. So immune mechanism, which is prevalent in endometriosis, they have the same importance in cardiovascular diseases too. It is clearly shown by Virchow in the 19th century that macrophage activation was prominent in atherosclerotic plaques. So we know that macrophage activation is prominent in endometriosis too. So innate immunity, which we call there's two immunity, adaptive and innate immunity. Mm-hmm. Up to 2011, innate immunity or we thought that macrophages didn't have any specific memory. But now we believe that there are very well controlled studies that those macrophages, neutrophils, dendritic cells, and natural killer cells has non-specific memory. Regarding that, when lifestyle modifications, some epigenetic modifications can change their reactions to the stimuli, and they remember that stimuli, and they maladapt the immunologic mechanisms. Instead of getting rid of the stimuli, they began to help to move up the stimuli and provide a inflammatory status leading to atherosclerotic plaques or atherosclerosis and endometriosis. Mm-hmm. So I think the next topic which will be important besides chronic inflammation or the basis of chronic inflammation is the innate or trained immunity that will form the basis of two studies. Because when you look at the literature at the same time, we know that endometriosis has seen a lot when you have chronic lower genital infections. The prevalence of endometriosis has been shown to increase. At the same time, when they're changing and good microbiota or dysbiosis, We know that macrophage or monocyte activity has been changing, and those both infections are shown to be related to atherosclerosis too. So I think the chronic inflammation and the innate immunity, epigenetically modified innate immunity, will form the basis of both diseases in the future.
I think that some of the topics you bring up definitely rekindle a lot of my medical school background now, having been a physician.
Yeah.
But it makes a lot of sense when you actually put it out there.
It's too simple. I mean, when you get low genital infection, you have increased prevalence of endometriosis. When you have gut dysbiosis or what you call microbiota changes in the flora, you may, it's linked to endometriosis, it's linked to preeclampsia, it's linked to premature labor, it links to atherosclerosis. So that it will be interesting to look at or to come out with very good studies, which I have to emphasize again. There's only one by Santoro and friends, which they worked a lot in that topic.
Makes sense. One topic that I found a little bit interesting, because something that comes up in our clinic here during my fellowship, and it's the link between endometriosis and early menopause, and you give kind of some rationale of why that's possible, either because of endometriomas or all the surgery that patients with infertility specifically have. So I had a clinical scenario I wanted to run past you and hear your kind of clinician viewpoint of what you would do. So the clinical scenario goes, a 39-year-old G0 with a history of stage 2 endometriosis and 3 prior pelvic laparoscopic surgeries where they might have done some excision and ablation, was recently diagnosed with primary ovarian insufficiency. What would you recommend in terms of this patient's global assessment from an ASCVD risk, and how would you manage her in your clinic?
Actually, and maybe fellowship knowledge or as a clinician, we have to first look at the risks. We have to get a detailed history of the patients, look at his background, if any have any kind of disease or not, check the necessary blood work with both cardiovascular disease and for menopause, and probably I would treat as soon as possible. Because as you know, in menopause, there is a timed hypothesis. So when you begin your therapy as early as possible, within 10 years of menopause, it's protective. We know that it's protective against atherosclerosis. So probably I would manage as I do same for any menopausal or patients. Of course, you can discuss what medication you are using. There are very good outcomes that are used on the topic. But our point is, before menopause, what should we do? Because we know that these patients are prone to, or there's clinical evidence that they have high risk of atherosclerosis in future. So they are young. And they are, it's known, it's published a lot. We know that in endometriosis, in Japanese study of 25,000 women, in endometriosis patient, early ovarian failure is prominent. So we know that there is something going on with menopause and endometriosis. We know that endometriosis changes the ovarian function, as I told you, beta receptor activation and progesterone resistance, following to epigenetic modification and macrophage activation. So we know that there is something going on. So our intention, not treating patients like those, of course we will treat as soon as possible, but to outline them and do some non-invasive tests, whatever you do, found out the risk and found denote the microvascular dysfunction or endothelial dysfunction in women, which is dynamic and reversible. We can easily reverse innate immunity changes or whatever dysfunction, and prevent before cure. But to your question, my answer is the same. Any clinician will reply. So we begin HRT or estrogen replacement therapy as soon as possible, without thinking that it will recur or not, and get a detailed, do a detailed physical examination and of course history and any background information regarding HSCVD risk, or maybe whether she had preeclampsia or she has G0. What we can any autoimmune diseases, which is closely linked to both endometriosis and atherosclerosis through innate immunity. So I would do the same. But again, I have to emphasize our intention is to prevent rather than cure atherosclerosis. And it should be known that in women, it is diagnosed 10 years later than the man, any cardiovascular events. And in women, the presentation is not typical. Therapy and outcome is not the same. Generally, we men come with atheroma plaques, but women, this microvascular dysfunction, there is no plaque, almost no plaque in most of the patients. So presentations, symptoms, therapy, and diagnosis is very, very different than the men in women. For that reason, as soon as possible, interfering with anything regarding the atherosclerosis is very vital in premature ovarian failure, as published in our literature a lot.
So you kind of alluded to this in some of your previous answers, but what do you think are some of the next biggest steps in terms of researching the association between endometriosis and atherosclerotic cardiovascular disease?
As I told you before, a very good design, very well designed, controlled prospective studies are needed because we have a lot of patients. Everybody is doing surgeries on endometriosis. We have at least outlined in our systematic review, which will be published next month, the non-invasive markers, clinical markers that we can use to outline the microvascular dysfunction in these patients. And there are new therapies are coming out, like metformin, statins. At the same time, we are using those in cardiovascular patients. At the same time, to suppress the chronic inflammation is endometriosis, but you know they are using a lot. There are some epigenetic modification to innate immunity that medications that may prevent those epigenetic changes, or lifestyle modifications that may affect those epigenetic changes in macrophage or innate immunity. So there are a lot of new data is coming. And those like statins, are used a lot in cardiovascular medicine, and it's the point of discussion. But now there are studies that they are using endometriosis treatment too. So I think well-controlled studies, well-designed studies regarding chronic inflammation, innate immunity, and their epigenetic modifications should be designed and should be looked carefully in both studies at the same time. There was an interesting advancement in literature. You know, American Heart Association, and ACOG came out with a statement like 6 months ago, stating that every woman who is going to obstetric or gynecologic examination should be questioned regarding the cardiovascular problems or the symptoms. This was very interesting. It's very supportive. It was very timely. We are about to submit this paper, and that came out, and that was supportive. But the problem with that paper, or to us, not the problem maybe, to us, there's a problem with that paper. They never mentioned endometriosis. But when you look at the non-traditional risk factors, we have preeclampsia, we have premature labor. Those are all in the literature related to endometriosis. In endometriosis patients, we see a lot of preeclampsia, increased risk of preterm labor, blah, blah, blah. So we have those. But when you look at that paper, they clearly outline those risk factors and non-traditional risk factors, which is very important in women cardiovascular health. But they omitted endometriosis. So we thought that while we prepared the paper, this is very supportive. So why didn't they include endometriosis? I think the data that we presented, or data we present systematic review, supports that there should be at least a question mark regarding endometriosis. If endometriosis is linked to premature labor or preeclampsia, why is not included in non-traditional risk factors?
Dr. Taskin, thank you so much again for your time and presenting this very novel and interesting topic. We look forward to your future publications on the topic and seeing whether or not more people pick up between the association between endometriosis and atherosclerotic cardiovascular disease. I really think that this is a great discussion. Thank you so much again for your time.
Thank you for having me. Thank you very much. See you, Peter. Thank you.
Thank you all for listening to another issue of MIGS Front Page. I hope that you tune in for the next video podcast. Have a good day.